A very good evening to all the delegates and welcome to yet another exciting W3 webinar series that is brought to you by the PCOS Society of India. Our corporate partner for today's activity is Metropolis. Can we have the next slide? So we have a very exciting discussion today, that is PCOS and endometrial cancer, can we prevent it? And we have an excellent moderator in form of Dr. Pankaj Desai sir today and a multidisciplinary faculty of experts who will guide us through this particular discussion. So good evening, everybody. I am your coordinator for today. I am Dr. Aditi Godbole. Our first expert is Dr. Alka Godbole, madam. Madam is a senior consultant and obstetrician and gynecologist practicing in Thane. And she has presented many papers nationally and internationally and is also the winner of the Thane Gunijan Award. Our next expert is Dr. Ranu Patni, madam. She is a senior consultant gynecological oncologist who's practicing at the MGU MST Jaipur. She is the trainer and mentor for Gynecological Onco Fellowship in Rajasthan, and Madam is the editor of the book Current Concepts in Endometrial Cancer. Our next expert is Dr. Swapnil Kapote, sir. Sir is a consultant surgical oncologist at Jupiter Hospital, Thane, and he has done a fellowship in breast oncology at Tata Memorial Hospital and a fellowship in endoscopic thyroid surgery at the National Hospital of Endocrinology in Vietnam. Our last expert today is Dr. Kirti Chadda, madam. She is a senior oncopathologist and chief scientific officer at Metropolis Healthcare. Madam is in the WHO panel of experts on cancer medical devices, and she has an area of interest in oncopathology, digital pathology, and artificial intelligence. I welcome all the panelists, and I request Dr. Pankaj, sir, to kindly carry on the proceedings from here.
Thank you very much, Aditi. You have really electrified the panel. The subject is very important. The subject, I love it. Therefore, all the more reason. As usual, we will start with a prayer. You are able to see my screen, I presume.
Yes, sir.
Yeah. Friends, today's topic is, in one word, very simple. That we as postgraduates knew this. Even we as postgraduates knew this. I'm sure Aditi must be knowing much more because she must have become a postgraduate after us. That PCOS has an association with cancer. And now we have to go deep in it and listen to and dig into the complicated part of it. And therefore, today's topic is both simple and complicated. The topic is very pithy. Aditi and the team has selected, can we prevent it? And that is where we generalists like me, Alka madam, we are generalists actually, even Aditi. We are generalists and we are not super specialists, but thankfully we have two wonderful super specialists also on the panel. You all are our teachers. I perceive you as teachers and I am representing the entire audience here. I am Arjun and you will have to teach me in the battlefield. I will be taking you with questions in the battlefield and you will have to catch hold of our hands and guide us through as this child is being guided by its teachers or by its parents. Very simple, to put it very simply, women with polycystic ovarian syndrome have a 2.7-fold, that means nearly 3 times higher incidence or increased risk of developing endometrial cancer. And we all know this, that a major factor for this increased malignancy risk is prolonged exposure of the endometrium to unopposed activity of estrogen. You know, everything should be within limits. Estrogen is very important. But the Madhyam mark of Buddhism, which we all appreciate so much, and those of us who are in meditations for deep know this, that estrogen should be unopposed, should be opposed. And that is where the horse comes in, where one rein is the estrogen, other is progesterone. And that is where the horse goes on. But if anywhere it goes out of control, then the horse turns and we know what could be the consequences. So we now come to the cancer. First, let us identify the risks of cancer. Once we identify the killers, then we will be able to understand them much better so that we can attack them. Once you know the enemy, you can attack it. And we have two wonderful super specialists here. Dr. Ranu Patni, who is a gynae onco, a friend of now nearly 30 years from Jaipur. And of course, we have Dr. Swapnil, who shares something very common with me. Our wives are gynecologists. So, ladies and gentlemen, my first question to Ranu, and that is, what are the most consistent clinical risk factors that you see in your practice and which we should, as generalists, should be aware of in subjects with endometrial cancer and PCOS? Ranu, please.
Yeah, first of all, thank you to Dr. Durusha and the whole team. And it is indeed an honor, Dr. Pankaj sir, to be a panelist. I still remember your encouragement for my first presentation. Thank you so much, sir. So actually, as you very rightly said, we get endometrial cancer as endometrial cancer and hardly as polycystic ovaries. But yes, there are actually, if you look at my practice, there are two age groups which I would like to refer to. One is people who are above, ladies who are above 50, and one is ladies who are in their 30s, 40s, and so on. We are seeing more and more of young patients with endometrial cancer. So if you ask about a history of polycystic ovarian syndrome in a woman who is 50 and above, she will hardly ever remember, because in those days it was not it was not diagnosed so much and hardly detected and treated. If you ask a younger woman, maybe she will give you a history of PCOS having been diagnosed earlier on. But the common things that we see in almost all, not all, but almost all patients is, one is obesity. Obesity does increase the risk of endometrial cancer, as we know, with increasing BMI. If it is more than 33 times, more than 32, 4 times, and so on. So obesity is a consistent factor. Yes, we do have lean and thin women with endometrial cancer of type 2, but they don't form the majority. Then, of course, hypertension, diabetes. It might be controlled, it might be uncontrolled, but yes, hypertension, diabetes, obesity, and dyslipidemias, these are consistent factors in almost all women with endometrial cancers who present to us, especially in the elderly ladies.
Dr. Ranu, thank you. Your answer, though you and Dr. Swapnil are seeing cases which are already probably diagnosed, these messages of yours are going to sensitize we generalists. We might be the first touch people who might be actually, we become sensitive, then we will be able to pick this up and convey messages to our patients. And that, yes, now obesity is, is a world, WHO has declared it as a worldwide pandemic. And since 1971, and that is multiple reasons, we will not go into it. But once we are conscious of it, we will look at it in this way and make our patients what we call sensitive about it. So let us see some database recommendations on this. Most of it you have already covered. If you have comments on any of these to add, please let us know. We would like to take advantage of your presence here. Of course, you said women between age 50 to 70, overweight, unopposed estrogen, hormone therapy, which I think menopause, in the menopause age group, which was given long back, is now not given for treatment of menopause. Also because when menopause was considered as a disease, this was being done, and which has thankfully stopped. Medications such as tamoxifen. Ranu, your comment on this, and complex atypical hyperplasia. Should complex atypical hyperplasia warrant an immediate reference to you, or no, we can still treat it?
Yes, definitely. About tamoxifen, it does increase the risk of endometrial cancer, given very, very commonly to treated breast cancer patients.
A comment from Dr. Kirti. Sorry, can you unmute yourself? Yeah. About this.
I wanted to make a comment on that complex endometrial hyperplasia that you very correctly said. So, very often, the situation is in front of you. There is definitely an endometrial hyperplasia. It's important to say whether it's, simple, complex, but it's more important to say whether there is atypia or not. And you'll be surprised. It's more common than we think. We can call it either CH or complex endometrial hyperplasia, atypical hyperplasia, or endometrial intraepithelial neoplasia, EIN. And Pankaj sir, 25% of these ladies, they develop carcinoma. So 1 in 4. So definitely it warrants a gynec-onco opinion and surveillance because, if the ladies, most of them take them up for surgical treatment. I just want to finish.
One point. Tamoxifen. Please, something on tamoxifen. How often you see that history?
So there again, it's very interesting, So tamoxifen does show changes, right? So obviously the endometrium looks different, but I don't see that much of atypia and carcinoma in tamoxifen patients because I think they are anyway very well managed by the oncologist where, they, buffer it with some, progestins and other things. So we do not see that much of malignancy in tamoxifen.
Yeah, Ranu, your point.
Yeah, actually, tamoxifen is right. I want to add something about complex atypical hyperplasia, or we call it EIN nowadays, endometrial intraepithelial neoplasia. There are many instances when these cases are taken up for surgery, and in almost 30% or so, after surgery, they come out as invasive endometrial cancers.
Okay, Swapnil, please. How often you see this? Women who have had colon cancer before the age of 50 and endometrial cancer.
So it's not a very common finding, but when it happens like in a regular way. These people who have had colon cancer before the age of 50, they might be suffering from something called as Lynch syndrome, which is also, we call it as HNPCC, hereditary non-polyposis colon cancer. They have a mutation in the MMR gene, which leads to development of colorectal cancers at an early age. Generally in their 30s and 40s, they will present with colon cancer. We also see a lot of other cancers associated with this Lynch syndrome. Commonly, we see ovarian cancer, endometrial cancer, breast cancer, pancreatic cancers, and urothelial cancers, gastric cancer. So there is a whole bunch of cancers which happen in patients with Lynch syndrome. And they will also, all the other cancers will also be at an earlier age of presentation as compared to what we would see in a usual group of patients.
Brilliant.
So,
Brilliant.
So what we see is endometrial cancers in patients with Lynch syndrome happens generally at a median age of about 47, 48, like that. And so if a patient is diagnosed with colon cancer with Lynch syndrome, we will put that patient on surveillance for endometrial cancer. If the patient's family is not complete, we ask them to complete their family and then, go for a prophylactic hysterectomy.
I'm coming to that. Swapnil,
okay.
We are requiring that. Yes. Swapnil, we are still on you. And everything nearly you have covered in this Lynch syndrome. Some forms of skin cancer also?
Yeah, so basically there are many cancers. The list which is on the screen is like maybe half of them which are associated with Lynch syndrome. But skin cancer is one of the rarer ones which Lynch syndrome will have. The commonest that we see are colorectal, ovarian, breast, endometrial, and some stomach cancers.
I want Alka madam back. Alka madam, I need your help because this is what you and me are going to do in our outdoor.
Yeah.
And that is how to reduce the risk of endometrial cancer in subjects who have PCOS. Please.
Yeah. First of all, I'll try to improve the patient's diet, nutrition. My approach will be on the history. Whether the patient is suffering from overbleeding, heavy bleeding all the time, Generally, these PCOS patients are in habit of prolonged amenorrhea followed by heavy bleeding. So this gives us the indication. Then second will be her BMI. Those are always obese patients. So we will have to do the counseling about their diet and proper diet and nutrition. Then third will be controlling their diabetes. Many of them are having high blood sugar, high serum insulin levels, and high BP, like that. Then main thing is the other second important from heavy bleeding is generally they have given hormonal treatments. Main is restrict the use of estrogens, which is causing this, which is a culprit, in fact, of having endometrial cancer in these patients.
This is what 2020 data tells. As you mentioned about treat your PCOS, maintain healthy body weight, avoid fats in diet, get frequent pap smears and pelvic examinations done.
Yeah.
Okay, for PCOS subjects. Would you like to do that?
No, frequent, according to me, frequent pap smears will not help.
No.
Only the history, that is of heavy bleeding, that only indicates.
Okay, thank you. Having PCOS, now this is what we should convey. And that is where you and me come in, and probably our Aditi comes in. Having PCOS doesn't mean you are fated to develop endometrial cancer. I have patients who are morbidly afraid of PCOS, not because they have PCOS, but because of this risk of cancer. Yeah. I have them. So, but this is the message which we can convey, if you agree, that it doesn't mean that you are at an increased risk of disease compared to women without PCOS.
Yeah.
Yeah, there is a statistically high chance. So be alert, but don't be afraid.
Yeah.
Okay, thank you.
That's true.
Now this is where our sheet anchor comes in. It is said, Kirti, that, surgeons, they do everything. Our Swapnil, surgeons do everything, but they know nothing. Okay, physicians, they know everything, but do nothing. Okay, gynecologists, they say, the obstetricians, they do nothing, know nothing, delivery occurs. Okay, but pathologists, they do everything, they know everything, but they are always one day late. Okay, so now we bring in our sheet anchor, Kirti.
Now, when you talk about can you determine the risk, right? So let us remember only 5% of endometrial carcinomas are hereditary or familial. Rest of them, as you elucidated right now, are all because of multiple reasons, right? So let us look at these two things separately.
Can you please repeat the statistic? 5 to 10% only are hereditary.
Only 5%, sir. Only
5%.
So
okay.
5 to 10% of breast cancers are hereditary, right?
Okay,
While just 3 to 5% of endometrial cancers are hereditary.
Now
So
hold your guns. Just hold your guns. Then this statement, which has come in 2021, seems to be right. They did a Mendelian randomization study,
yes,
and they said our results indicate that genetically predicted PCOS might not be associated with the risk of endometrial cancer.
So I was coming to exactly this, sir, right?
Exactly.
So now when we separate these two, so now we have segregated the endometrial cancers. Now we have segregated them morphologically, we've segregated them molecular, right? Now we are trying to segregate the risk or the reason or the etiopathogenesis. Now that is, as I said, 90 to 95% are because of all these reasons, which already you all know better. You all tried to prevent them. And when the Mendelian randomization randomization is done for this, there are many common factors like hyperinsulin, obesity. I mean, it's not, you cannot attribute it solely to a, PCOS or to endometrial cancer, right? So obviously, and the diagnosis also, everybody has their own way of diagnosing it. Then, I think there is, as you said correctly, this statement is correct. So
Aditi really made me work very hard, and Guru always makes me work very hard. And these are some stray observations, but I want your indulgence and comment on this. Okay, endometrial cancer starts in the lining of the uterus, the endometrium. Okay, being overweight or obese greatly increases a woman's chance of developing endometrial cancer. Yes.
Yes.
Other risk factors include age, family history, a diagnosis of PCOS, and prior use of breast cancer treatment drug tamoxifen. From all what you have said up till now, these are the things which are becoming clear already. Okay, Alka madam, still with you. The healthy lifestyle.
Yeah.
Alka madam, does lifestyle change really have much effect on prevention of EC associated with PCOS?
Yeah. Lifestyle has got much more effect than any other thing except hormones and other medication. But main thing is we should avoid estrogen therapy. So now
unopposed estrogen therapy. Unopposed estrogen.
Then unopposed estrogen therapy should be avoided. Second main thing, obesity should be avoided. BMI should be less, around 25, 26.
And madam, still with you, Alka madam, just a last point. We included 15 studies, 498 participants, and where weight and BMI will improve the free androgen index, and therefore your message goes fine and clear. How good is progesterone in prevention of this cancer?
As such, in cancer, when it is diagnosed, we don't prescribe generally progesterone. Prevention is better with progesterone because it is very much effective.
We have excellent papers on LNG-IUS, and nowadays they are even recommending. Your comment is welcome, and even Ranu can tell us something on this. You do a DNC. There is an irregular menstruation, history of PCOS, woman around 38, 40 years of age. Encourage LNG-IUS, that is what they are telling. And that will help in reducing the risk of endometrial. Ranu, you agree? Would you like to encourage us in such cases where irregular menstruation is there? We do a DNC, rule out a malignancy, before that an ultrasound, and then encourage LNG-IUS?
Yes, LNG-IUS can be used if we have ruled out histopathologically, we have ruled out malignancy. But here again, I would like to say if she's a high-risk woman, like a family history or a lynch in the family or something, then I would not suggest, because in 30 to 40% cases, like I said earlier also, the final histopathology does not, on hysterectomy, does show malignancy in cases of endometrial.
So can you please repeat your message? LNG-IUS, yes or no?
Yes, it can be used if we have ruled out high risk and endometrial cancer.
Alka madam, still on you. This is the combination which has become very popular nowadays. Is in market. Recent articles from throughout the world are indicating a good efficiency of cyproterone, which is given in PCOS, plus ethinyl estradiol in reversing CA changes in subject with PCOS. Do you agree with this? Partially. Okay. Where do you, because they say that this combination has got a capacity to induce autophagy and apoptosis, which will be music to the ears of Kirti. If she finds this autophagy and apoptosis evidence, she will be very happy because the results are going to be excellent. Yes. And even Swapnil and Ranu, because if that report comes, they will be very happy. So can we use this? What do you feel about it?
Yeah. We can use this,
2022,
additionally.
2022
this is very good.
Article is there that the results and previous clinical evidence support the use of this agent. So LNG-IUS and this is a very popular combination with PCOS, and therefore it is encouraged that if you are using this, please continue. Now we come to Ranu, and Ranu, this is where Metformin comes in. Okay. How good is Metformin in prevention of EC associated with PCOS? Very quickly, EC is endometrial cancer, PCOS you all know. Ranu, please.
So Metformin as per se will not prevent endometrial cancer, but it will prevent or it will treat polycystic ovarian syndrome. Thereby, it will prevent progression to endometrial cancer.
Okay, so indirectly
it does so. Sorry.
Indirectly, it can help.
Yeah, indirectly. So it does so by lowering the androgen levels, by reducing weight, maybe by insulin sensitization and indirect effects. So that is how it will prevent polycystic ovarian syndrome and then thereby endometrial hyperplasia and progression.
I am attracted to, but I will not indulge in it. That I want to ask you, what about the other combinations, fanciful, which have come in? Does Metformin still rule? But then that is not our agenda. The agenda that will be when PCOS is specifically discussed. So, okay.
Here I would like
right, Ranu, because see here also, this is a paper which has come in 2019. Our findings suggest that decreased glycolysis and increased mitochondrial activity might contribute to onset of ER-alpha dependent endometrial hyperplasia, and that Metformin might directly reverse the impaired glycolysis and normalization of mitochondrial function in PCOS patients with endometrial hyperplasia, and completing with Ranu's words, and thereby indirectly helping in progression to malignancy. Now we come to the current flavor. And the current flavor is this Vande Bharat. Do you know that the Vande Bharat bookings, the statistics have shown, can go up to 127%.
Oh.
127%. This is the popularity. I am bringing in our surgeon sir, Swapnil here, to comment on bariatric surgery, which is the current flavor in PCOS and in general surgical practice also. Please.
Sir, so we have been discussing that, obesity is the major risk factor for CA endometrium. So it makes sense for us to think that something which reduces obesity should help in reducing the, the incidence of endometrial cancer. And why obesity is so strongly associated with endometrial cancer is because it causes inflammation, it causes hyperestrogenemia, and it causes insulin resistance. So that's all these changes will cause changes in the various oncogenic signaling pathways, and then many cancers are associated with obesity, predominantly endometrial and breast cancer. So there was a meta-analysis published in 2018, and what they found was, in the number of, I think, 5 studies, found that the chance of endometrial cancer developing in a person who has undergone bariatric surgery was about 0.4%, whereas the chance of developing endometrial cancer in the normal population is about 1.4%. So there was a decreased incidence of endometrial cancer in patients who have received bariatric surgery. However, this is a meta-analysis, and I couldn't find any RCT or randomized control trial to corroborate that. But I am sure, this will be investigated in the future. Just to give you a hint, there is a trial which is accruing patients right now, based out of Women and Brigham's Hospital in Boston and Dana-Farber Cancer Institute in Boston. And they are accruing patients who will be candidates for bariatric surgery along with endometrial cancer. So they will undergo a hysterectomy along with a bariatric surgery. And the accrual is going on. They are expected to finish accruing by 2024. And we should really look forward to the results of this trial, whether it is a feasible option to do this kind of, treatment. So yeah, there is great interest in bariatric surgery in endometrial cancer, but we are not there yet.
If that gives you a pause, that's accrual surgery data tells you that yes, this might help. Will you advise your patients in whom you are treating surgically, morbidly obese, CO endometrium, to do a concurrent procedure, a pediatric this? Are you open to it?
Yes, of course, sir. Because we will hit 2 birds with 1 stone kind of. We'll get take care of their obesity and will take care of their endometrial cancer.
Thank you very much.
So,
Thank you very much.
Yes.
Thank you very much. It is very heartening to get such answers. Thank you. Madam, I know many of you must be hungry. My dinner time is over. Actually, I take dinner at 5:30, but not on Saturdays. Saturdays we go out for dinner. So food, something everywhere. सब लोग पूछते हैं.
Yes.
Pregnancy में बहुत पूछते हैं क्या खाना चाहिए. और now we tell only one thing. आपका हस्बैंड जो खाए वो खाना चाहिए. ओके ये नहीं बोल सकते हैं कि हमारा सर नहीं खाना चाहिए, पर आपके हस्बैंड जो खाए वो खाना चाहिए. मैडम फूड आपको लेके आता हूं मैं. What foods reduce endometrial thickness? Any idea on that?
Actually speaking, from my point of view, what we eat every day is the good food, normal balanced diet. What we are eating since our childhood days, that is more fibers, just like only rice, dal, chapati and sabji, dahi or buttermilk is enough. For non-veg eaters, fish is the most good, but try to avoid red meat mainly and fatty foods. This is the basis of all diets. Generally, we try our patients convincing that try to avoid this and this and this, because these are young girls, very fat. If we tell them eat more leafy greens and all this, ये क्या घास फूस खाना है ऐसा पूछते हैं. So I try to avoid them giving dietary advice much more. Only I tell them once in a while you can eat outside food, that is pizza, burger, what they like. This generation is on pizza and burgers only, because whatever we tell, if we tell them eat every day leafy vegetables in form of only dry or something, they will not agree.
They will run away from you.
Yeah.
Okay.
So,
madam, your point I am corroborating. In this data, actually this is a data-based answer. You mentioned about fish. See all of these: salmon, sardines, herring, trouts. These are all fishes. Okay, everywhere these are the things which have been advised. So, but then I'm making your life a little more uncomfortable. And there comes the, do you feel there is a gene-nutrient interaction that has an important role in PCOS? Gene-nutrient interaction?
Actually, I'm not sure about this. So
okay, no, I have the answer to this. 2021 reference is there, madam. Gene-nutrient interactions are important contributors to health management and disease prevention. Nutrition can alter gene expression. They will not change the gene structure. So that is where they are knocking at the doors of epigenetics, as well as the susceptibility to the disease, including cancer, through several mechanisms. Gynecological diseases in general are diseases involving the female reproductive system and induce benign and malignant tumors, infections, and endocrine diseases where the gene-nutrient interaction may have a role to play. Our audience, and keep this in mind, please keep this in mind, that interaction also can change. Gene structure will not change, but the interaction can change. Before we started, regarding CA endometrium, it was only this: either you do everything or you do nothing. Okay, this was what was the attitude. But thanks to these teachers, all four of you, we are now ready to fight. And when I say we are generalists. We are much better equipped. I am honestly telling you. Tomorrow when I sit in, not tomorrow, Sunday, Monday, when I sit in my consulting, the first patient of this type I get, thanks to all four of you, I am much better equipped to fight. Thanks to you, that now I can behave like this. I am ready to fight. Okay. And this all because we want to serve humanity and mankind with complete dedication and complete sincerity. I would like to thank
sir,
all of
thank you.
Having us.
Thank you, sir.
Thank you very much, my teachers. Thank you.